Very good evening to all the respected teachers here and all those who have joined. I'm Dr. Gopambuj. I'm doing my DM nephrology from IPGMER Kolkata, and today I'll be presenting the monthly journal club. The topic of the journal is, as sir told, it is the Lockheed 100 study, taurolidine heparin lock solution and catheter-related bloodstream infection in hemodialysis. We'll go through various points of the study, and in the end, we will discuss about the conclusion and other aspect of the study. So, first of all, the introduction. Hemodialysis patients, as we all know, are at high risk for bloodstream infection. It is because there is need of frequent vascular access via central venous catheter, and the host is already immunocompromised. Catheter-related infections are associated with high risk of mortality, and they can lead to complications like metastatic infections. Prevention of CRBSIs is an unmet need in hemodialysis. Coming to the lock solutions for CVC, heparin is the current standard of care catheter lock solution to prevent the thrombosis, but it has no antimicrobial properties. Taurolidine heparin catheter lock solution is an investigational drug for CRBSI prevention in patients who are receiving hemodialysis via a central venous catheter. This study reports the result from a phase 3 Lockheed 100 study designed to evaluate the efficacy and the safety of taurolidine heparin catheter lock solution compared with heparin control for the prevention of CRBSI in participants with a CKD 5 HD via CVC. Coming to the taurolidine heparin catheter lock solution, as sir told, uh, the US FDA has recently approved, just a week back, they have approved this DefenCath, which is taurolidine and heparin, to reduce the catheter-related bloodstream infection in adult patients with kidney failure who are receiving chronic hemodialysis through a CVC. DefenCath is indicated in this limited and specific patients population. The mechanism of action, the taurolidine denatures the surface proteins and chemically alters the membrane lipids. The taurolidine has broad spectrum antibacterial and antifungal activity and a mechanism of action that does not lend itself to microbial resistance. Antimicrobial resistance has not been identified in vitro or in clinical use for taurolidine. Coming to the study design, the name of the study is Lockheed 100. The registration date was 7th of January 2016. It was a randomized double-blind active control study which involved 70 centers from the United States, and it was a phase 3 study. The inclusion criteria were patient of ESRD with hemodialysis at least 2 per week, the catheter flow at least 250 ml per minute, the internal jugular or subclavian site with tip in RA SVC junction, the life expectancy of the patient at least 180 days, the CVC use for at least 60 days going forward, the single pool KT by V more than 1.2 over last 30 days, and women of childbearing potential with negative pregnancy test and a reliable contraception. There were exclusion criteria which were antibiotics within last 14 days. There were if the exit site was compromised, if there is RTPA use within previous 30 days with catheter, a current catheter, and if the fill volume of the catheter lumen is unknown, if there is use of antimicrobial or heparin coated catheter, if there is active or chronic bleeding diathesis in prior month, uh, hypercoagulable status or atrial thrombus, open non-healing ulcers, immunosuppression that increases infection risk, like more than 50 milligram per day of prednisolone, and active malignancy. These are the coming to the method of the study. The eligible participants after randomization were divided into two arms, taurolidine heparin and heparin only, which was to be instilled after hemodialysis and removed before next hemodialysis. They continued study visits on dialysis treatment days when standard laboratory data for maintenance dialysis were collected, and a final safety visit occurred 28 days after removal of the last dose of study drug. This is the study flow diagram. First, there was enrollment of around 1066 patients, and then there were randomization of 806 patients. 260 patients failed in the enrollment process, and the randomization was done in 2 arms, and allocation was done, and then follow-up and analysis was done over the analysis population. The primary endpoint was time to CRBSI. The secondary endpoints assessed the impact of the study drug on the catheter functioning and included catheter removal for any reason and loss of catheter patency. All the endpoints underwent clinical adjudication for the trial. The definition of the CRBSI was taken as if there were one or more, like fever at or above 37.8 degrees Celsius, and rigors documented by a medical professional, and 2 or more of tachycardia more than 100 beats per minute, tachypnea more than 24 per minute, and systolic blood pressure less than 90 millimeter of mercury, or decrease in systolic blood pressure, which is more than 30 millimeter of mercury. And there is obvious change in mental status from documented baseline. Along with that, there should be one positive blood culture, which is other than for coagulase negative staph, which requires confirmatory culture. And the culture would have been taken from a peripheral venipuncture or the arterial or venous dialysis port, or the venous or arterial dialysis circuit blood lines if on dialysis. Coming to the statistical analysis, this trial was designed to achieve 80% of the power for comparison of the primary endpoint between the study arms. In total, there were 56 CRBSI events which were needed to achieve the desired power. The primary endpoint was analyzed in 2 parts, first in the interim analysis and then at the study completion in the full analysis, included dose of the study drug. A Cox proportional hazards model was used to estimate the hazard. Am I audible, sir? Hello?
Yeah, you are audible.
Yes. Cox proportional hazards model was used to estimate the hazard ratio with 95% confidence interval. And the CRBSI incidence rate, which was the number of participants with CRBSI divided by the total number of catheter days of follow-up, was calculated for each group. Catheter days were counted as the number of days from randomization until the occurrence of either a CRBSI or sensitivity. The CRBSI rates are presented as the event rate per 1000 catheter days with a 95% confidence interval. A pre-specified sensitivity analysis of time to CRBSI in the full analysis population was performed, in which cases considered to be indeterminate were treated as CRBSI. The primary endpoint was also assessed in the full analysis population using hazard ratios for specified subgroups on the basis of baseline characteristics, which were age, race, sex, time since first dialysis, and catheter location. The secondary endpoints of time until catheter removal for any region and time to loss of catheter patency were analyzed using similar method as for the primary analysis. The secondary endpoints were analyzed in the full analysis population using a fixed sequence testing procedure. These 2 analyses comparing the 2 groups for catheter loss for any region was to be formally conducted only if the primary endpoint analysis yielded a statistically significant result favoring torlidine heparin. The analysis comparing loss of patency was to be formally conducted only if the analysis for catheter loss for any region also yielded a statistically significant result favoring the torlidine or heparin. Then the safety analysis were conducted on the safety population, which included all the participants who received 1 or more dose of the study drug. The adverse event data were also collected from day 1 through 28 days after the last removal of the study drug. And statistical analysis were conducted by an independent statistical group. These are the results of the baseline characteristics. The baseline characteristics which were analyzed here are age, race, ethnicity, time since first dialysis in months, time receiving dialysis, and then catheter location. The age category were divided in three parts: less than 65, 65 to 75, and more than 75. And here in both the arms, the maximum patients were in the first category, which is less than 35 years, 239 in torlidine heparin and 236 in heparin. Again, the race, the most of the patients who took part in the study were whites, which were 248 and 262 respectively. The ethnicity was non-Hispanic and Hispanic. The BMI and diabetes status was also considered, and the time since first dialysis was taken. The mean time was 21.2 in torlidinum and 19.8 in heparinum. The time receiving dialysis, the most of the patient fell into the category of 1 to 12 months, 237 here and 246 in the heparinum. While the catheter location, the most common location of the catheter was in the jugular vein, 371 in the torlidinum and 365 in the control arm. The second table here, it shows the time to catheter related bloodstream infection in the full analysis population and interim analysis. During the interim analysis, in the torlidine arm, the participant with CRBSI were 6, while in heparin arm, they were 22. While at the completion of the study, the participant with CRBSI in torlidine arm were 9 and in heparin arm were 32. And the p-value, which was significant, is 0.001. This is the Kaplan-Meier survival curve for time to CRBSI through the whole 24 months. Here we can see that the proportion of the patients who are at risk initially, means who have been taken here initially were 397 and 398, and with a gradual time, with a gradual progression of time, the uh, red line here shows that the patients who are given heparin, while the blue one shows that the patient who are given this toluidine, and here we can see that with the passage of time, here we can see that in the toluidine arm, the proportion of the patients remains greater as compared to the proportion of the patient which were given heparin. It shows that the event because of which the catheter was removed or any other adverse event were lesser in this population, in taurodidine population, as compared to the heparin population. And gradually the study was completed, and after that there is a plateau in both the arms. Now coming to the secondary outcome of the study, and it was the time to catheter removal and reasons for removal of the catheter. The time to catheter removal, the median time was in torlidine arm, it was 197 days, and in heparin arm, it was 225 days. The p-value was 0.42, which was not significant, and the catheter removed because of improvement in 162 and 132, and the catheter removed because of CRBSI or catheter malfunction is first here in the participant with catheter removal because of CRBSI, catheter malfunction or any reason, which was 74 in torlidine arm, while it is 93 in heparin arm. While the catheter malfunction or dysfunction, the loss of patency was in 28 patients in torlidine arm and approximately similar in heparin arm, which were 26. The event rate per 1,000 catheter days were 1.09 in the torlidine arm and 1.34 in heparin arm. The safety analysis, which was also conducted, any treatment emergent adverse event, most of the adverse events were mild to moderate, while severe life-threatening were very low. Life-threatening adverse events were in 22 patients in torlidine arm and approximately similar 21 in the heparin arm. The serious treatment emergent adverse event related to the study drug was only one in the torlidine arm, and there was no such event in the heparin arm. Now coming to the discussion of these points, The torlidine heparin significantly reduced CRBSI in participants receiving hemodialysis via central venous catheter for the treatment of kidney failure compared with heparin. There were no significant differences in rates of catheter removal for any region or loss of catheter patency between the study arms. The safety profile for torlidine heparin was comparable with that of heparin. The finding of this study of a 71% reduction in CRBSI with the use of torlidine heparin is consistent with the finding of two earlier studies in hemodialysis patients. The first study, Solomon et al., found a 59% reduction with the use of torlidine heparin in all bloodstream infections, including those not catheter related. And Murray and colleagues reported a 56% reduction in all staphylococcal infections. The result of this study are also consistent with a randomized controlled trial in 106 participants receiving hemodialysis via central venous catheter, which reported a CRBSI rate of 0.67 per 1000 catheter days with a torlidine-based catheter lock solution versus 2.7 per 1000 catheter days with a citrate solution. In this study, the rates of total catheter dysfunctions and catheter removal because of infectious and mechanical complications were significantly lower in the torlidine group. Similarly, a meta-analysis of the efficacy of torlidine lock solution in reducing CRBSI in children reported a 77% reduced risk of CRBSI with torlidine versus the control. Coming to the future impact of the study, the result of Lockett 100 clearly document a substantial reduction in CRBSI in CVCs used for hemodialysis. Early termination of the trial shows the magnitude of this effect, which will likely result in a significant reduction in morbidity and mortality, as well as better utilization of scarce healthcare resources. A reduction in CRBSI may result in an improved quality of life in this due to reduced hospitalization with significant clinical and public policy impacts. The availability of torlidine heparin will facilitate precision medicine approach to vascular access care by benefiting patients of access crisis. Given the continuing need of some patients to dialyze via CVC, a safe and effective antimicrobial catheter lock solution will play a very important role in reducing CRBSI in this patient population. Reducing CRBSI in hemodialysis patients will likely increase the efficiency of care and reduce the number and duration of hospitalizations and overall costs. So the conclusion of the study was that the torlidine heparin, a novel antimicrobial catheter lock solution, significantly reduces CRBSI risk in the patient receiving hemodialysis via central venous catheter versus the standard of care heparin without any safety concerns. And these findings support the use of torlidine heparin in HD patient to reduce the risk of CRBSI, which are associated with very significant clinical, economic, and quality of life burden in this vulnerable patient population. Now, before I conclude my presentation, I would like to add I'd like to show these two slides which show the CRBSI in our population in Indian setting. And there is a study from KMC Manipal. And in this study, there were total of 921 catheters were included, out of which 212 had CRBSI, of which 69 and 143 had culture positive probable CRBSI and culture negative possible CRBSI. And the conclusion of the study was that the incidence of CRBSI was high in our population. Another study is there in which the low concentration trisodium citrate as a non-inferior locking agent for non-tunnel dialysis catheter in the Asian setting. This study was also done. And this study showed that though there is the number of CRBSI episode per 1000 catheter days for the citrate and heparin group, but 2.7 and 2.9, but the citrate catheter lock cost only 6% of that of heparin lock. So by showing these two slides, I just wanted to show that first, the incidence of CRBSI is very high in Indian population as compared to Western population. And second, that the cost is a big issue in our population. Thank you, sir.
Thank you, Dr. Atul. I'll now like to invite Dr. Kher and Dr. Amit Gupta to comment on the presentation about the methodology and about some inputs to the student and how he can improve upon his presentation. And then the floor is open for the question and answer session for the authors.
Kher, would you like to start?
Amit, you can go ahead. Start with.
You can start. Amit.
Yeah, I think it's such a pleasure to have both Anil as well as Prabir here on this. Can we switch off this? You can. Maybe yes. Yeah, it's good to welcome both Anil and Prabir on this in this discussion on a very important topic, and especially more relevant, very, very relevant for Indian conditions, because I think more than 90% of our patients, probably more than 95% of our patients, start with either a tunneled or a non-tunneled catheter dialysis, and then over a period of maybe next 6 months or so, an AV fistula is created, and then many of these patients on maintenance hemodialysis would continue. But significant number of patients, which could vary from 30 to 50% also in many centers, would remain on tunnel catheters. And you can see that the incidence of infection as shown in these two studies has been very, very high, and it continues. In many parts of the country, there would be. And unfortunately, there has not been a very good antibiotic lock system for these catheters. And can we switch off everyone else? I think there's some noise. So I would think that this study definitely, there have been many studies earlier, and these were not large studies, but I think this large phase 3 trial by Anil and Prabir has very convincingly shown that taurolidine is a antibiotic lock, which will decrease the incidence of CRBSI in these catheter dialysis patients. I have one or two questions for both Prabir and Anil, and I think probably they might answer that. What would be the cost of this is now that it has been approved by FDA? What's the cost of this agent in US? I don't know if it is available yet in India. And what would be the cost implications of this in our country? Because in our country, obviously, many patients pay for their dialysis, so therefore cost becomes an important element. In many of our centers, people have used different kind of locking. Dr. P.P. Verma, who probably may be in the audience itself, has been using alcohol, and he had a poster at the ASN this time. And he has been using absolute alcohol, diluting it, and then he says that it's an effective locking system for the catheters, and says that the infection rates are lower. Now, I haven't looked at the data that carefully, so I wouldn't be able to tell. Maybe Dr. Verma would talk about this at some point of time. Anil, any one of you would want to?
Ravi, okay, if I
why don't
you
go first?
Go ahead.
Yeah, Anil. No,
okay.
Anil, you go first. Yeah.
All right, no, thank you. Looks like we are both from Lucknow or something. Say, Pale up. Thank you. So, first of all, thank you very much for inviting, and thank you very much for choosing our article for the Journal Club in India. It's very, very important if you consider that 90% of people in India start with a catheter and 80% start in the United States. It's not much better. Catheters infections, they still remain prevalent. It's an unmet need to prevent infection, and all we have is generally what we use and might be the same standard in India as well, to use just heparin for the heparin log solution. Sometimes citrate. I've heard about the alcohol before, but there is no large trial of that. So there has been data, and I'm giving a little bit of background before we go into the cost issue that you asked. So there has been data over the last 3 decades. There have been a number of trials of antimicrobial log solutions. So there are some questions here in the chat about, is heparin the standard of care for antibacterial prophylaxis? There is really nothing like that is utilized. What you use for comparison, what is being utilized everywhere else, which is heparin, not for the specific purpose of infection prevention. If you think about the any catheter log solution has 2 roles. One is to prevent clotting so that it remains functional, and one is to decrease infections. Unfortunately, heparin does not do anything about the infection. In fact, there is some evidence that the heparin can increase the biofilm formation. So it's not helpful. Very ironically, this is what we've been using, and it does not do anything for infection. So previously, people started experimenting with antibiotics like gentamicin and rifampin and whatever they could get their hands on, mixed with the heparin or citrate, and tried as antimicrobial log solution. And you'll be surprised to know that pretty much anything you mix with heparin or citrate, that decreased the amount of the number of prevalence incidence of infection in catheters. Unfortunately, nothing was available, nothing was approved. There were some solutions that were incompatible with each other. You mix gentamicin and heparin, it turns white. So there were concerns about it. So there was nothing really available at least in US, to use as a standard antimicrobial log solution. I tried to use it in my dialysis unit, and there was no. You have to have in US a pharmacist mixing the drugs. Yeah, you cannot just have the dialysis nurse mix the drugs. So it was just not practically feasible. So now we have this solution which is now approved. There is nothing available as far as the cost is concerned at this point. As you can imagine, there's going to be heavy negotiation between the pharmaceutical company and Fresenius and DaVita, and they will come to something. I'm pretty sure it will be definitely expensive and decently more expensive than heparin. But then you put it against. So you always have to think about the cost of the drug and the cost, that indirect cost that we are paying, or actually direct cost that we are paying. Every CRBSI is associated with anywhere between $17,000 to $32,000 of expense. There are a number of ICU days, number of hospital days that are prolonged way beyond the person who does not have CRBSI. So considering all those, I think, in my opinion, and I'm gonna just speak off the top of my head, it's the you will have to pick and choose. I don't think it will be something that you want to start using in everyone. I would be more keen to utilize it in somebody who has a higher risk of infection, who is on his last catheter, last access, where you cannot afford to lose that access, history of recurrent infections. Those might be so you may have to have that type of selection. Anything you have to be judicious. If you start using anything in everyone, it's not cost effective and it's not prudent either. So that's, I hope I answered some questions in the which different units are using.
Can I just ask you a couple of questions?
There is no antimicrobial solution, yeah. So the cost is going to be higher. Prabir, go ahead with your comments, additional comments.
Go ahead, Amit. I can go after you.
Yeah.
No worries.
No, actually, I just wanted to ask you, is that does this solution toluidine prevent biofilms? You talked about biofilm formation, and because that is one of the reasons why you have infections. And secondly, did you sort of look at, say, patients with diabetes and those who do not have diabetes? Was the effect the same, or the benefit the same as in both the cases. And why did not, I mean, you answered partly that previously the antimicrobial solutions that we were trying to use really didn't get any popularity. You said that because there was some interaction with heparin. But even otherwise, people have tried a whole lot of other antimicrobials, but they really didn't get, I mean, popular to be used. I mean, so do you think that what is the difference with this particular combination?
Is Prabir, can I answer first and then?
Yeah, please go ahead. Yeah, absolutely.
Sorry, since Dr. Gupta, thank you very much. All very excellent question. So there is some evidence that taurolidine actually prevents biofilm formation. Those are in experimental models. As you can imagine, it is very difficult in humans to take out the vessel and catheters and look at the biofilm formation in a standard way. It's very difficult, but potentially that might be one study that somebody may want to do in a small number of cases. But there is some evidence that it does reduce biofilm formation. The question about diabetes or no diabetes comparison, those will be, I think those studies might come out after this. I don't think there has been any further analysis of this data. Yet we just published this like a couple months ago, not even a couple months fully. And the previous antimicrobial locks were also not popular because, there was evidence of ototoxicity, for example, with the gentamicin lock solutions. And there were strains, bacterial strains that were resistant to gentamicin after utilizing antimicrobial lock solutions. So, for that reason, most of the lock solutions, antimicrobial lock solutions, were not being utilized for prevention because over long term you will have those side effects. So those were being utilized more for the treatment of CRBSI to save the catheter. So there's a different use. You can use it for prophylaxis or you can use it for treatment. And I will have Prabir. He has been quite waiting for me. So thank you.
No. So first of all, thank you for the invitation. It's very good to be here with all of you. I'm looking at between 75 to 80 people in this Journals Club. I just sent an email to Todd Ibrahim, our executive director at ASN, saying, "Is there something that we can learn from this?" So he's just got that. But I do think it's nice to have these journal clubs at a central level. And if you could just mute again, there's a lot of background noise. All right, so I'll make some quick points. So the first issue about cost, yes, the cost is hugely expensive, but I think that in different countries, the cost is going to be different based upon the benefit that you're going to get. So clearly the cost of a hospital admission or and other things it's going to be less in India. It's available now in the Middle East, for example, has been for some time. So I think the cost issue is going to be different in different parts of the world. So that's number one. I do want to speak a little bit, and we haven't spoken very much. Let me put it in order. The first thing, though, that I should have said, and this is sort of a call to action, we're all excited about the fact that this can reduce, catheter infection rates. The reason for that is that we have so many catheters. The answer to having so many catheters, of course, is to try and get rid of the catheters. So in a way, it's a paradox. Yes, this is good, but it's only good because we haven't been able to do a better job in trying to get rid of catheters. And I know that there are so many problems. Some are common between India and the US, others are different. Our catheter rate, I can tell you, in the US has pretty much stayed constant over the last 15 years. In fact, it's actually gone up by about 2% in the last 15 years. It's around 80% for all new patients. That's a disgraceful number. So for the younger people, yes, these new drugs are good, but let's also try and think about how we can be better at preventing this high use of catheters. The other point that I wanted to make, and we haven't really spoken very much about it, is that both in the control arm and in the taurolidine arm, not both, just in the, if you look at the control arm, we had a figure of about 0.5, 0.49 infection. The infection rate was 0.49 per 1,000 catheter days. That's a really low infection rate, right? Earlier, our infection rates in the US was actually similar to, it will be said it was between 1 and 4. But the bottom line really is, and this is the second message, is that in a study, I'm presuming people were more attentive to all the standard infection prevention things. I think many other places have shown that the infection rate in the control arm in these sorts of studies are actually very low, which means that if you do your infection prophylaxis well, even when you use heparin, you can get a really low control rate, right? So I think that's a second very, very important message. The third important message, which to me was disappointing in a way, was that I had always believed that when you have infection, it's obviously due to the biofilm, and the biofilm is linked to more dysfunction, right? So I'd always felt that infection, and this was just an opinion, that infection is linked to dysfunction of the catheters. And that didn't really seem to come out, because if that had been the case, you would have expected a lower rate of dysfunction in the treatment arm. So that was my third point. And the fourth point was really about, we have probably used, Anil, more than you have, the catheter lock solution. So for many years in Cincinnati, we actually did use gentamicin citrate in our outpatient dialysis units as prophylaxis. And we stopped really because of this. Anil's mentioned the ototoxicity. There were also 2 people who died in the northeastern part of the US, and they were using gentamicin catheter locks, and they had a gentamicin-resistant organism. So that is why gentamicin has sort of gone out of favor, and catheter locks, I would say, in general. At UNC, we still use gentamicin citrate locks for the period of time that patients are admitted into hospital, right? So it's not in the outpatient units, but at least for that, when somebody with a catheter is admitted into hospital, we still use them. But I think the distance issue and the toxicity issue is the things, looking at the chat, are the things against it. And then for General Verma, sir, I would say, I have to call General Verma sir, because I trained at AFMC, and General Verma was in the AMC as a Lieutenant General. Your point about catheter, about alcohol, good, and that's come up before. I do know that there was a lot of concern about the alcohol having a negative effect on the catheter material, but that may have been when there were more silicone catheters as opposed to polyurethane catheters. So, but I think that that's something that could actually be a very effective solution if it doesn't damage the catheter. And then the last point, and then I have to stop because, and I have, of course, it will hopefully come back. So I'll hand back to the chairs, to Amit and to Vijay.
Yeah, the other point was that the time to removal of catheters in both the arms was not significant. What does it signify, actually?
Go ahead, Ravi.
Yeah, so I looked at it to some extent that I looked at it in the sense that it's not that catheters cause some it's not that infection caused some dysfunction. The other reason that is buried within the paper is that there was a fair amount of censoring, and Anil may be able to speak better about the exact differences, but I've always taken it to say that that the infection doesn't necessarily cause dysfunction. The other part, Amit, I can start off with your answer, and it's actually a procedural thing. I think the people that had the infection were actually censored out. Anil?
Yeah, that's right. So the other thing is, if you think about it, it makes sense because in both the arms, the anticoagulant is the same. It is heparin. Taurolidine was used for the antimicrobial purposes, so it has the antibacterial and antifungal activity. So if you are using the same anticoagulant in both, I would not have expected a ton of difference unless what Prabir was just saying, that infection predisposes to dysfunction also. That were to be true. They did not come out in this, but not everything comes out. There was such a low rate of infection in both the arms. If it was a higher rate and there were a higher number of infections, then probably you would have a little bit more strength to tease out the differences. But I'm not surprised that there was not much difference. And in fact, if you look in the taurolidine arm, more catheters were removed because they were not needed anymore. So it was not because of the infections. I don't know if I answered. Yeah.
I thought for a journal club, this is for Dr. Rathod actually, I would have wanted, because he is supposed to analyze this article actually, and his purpose was not only to give us a summary of what is already written in this, but was also to critically evaluate whether, so it's a randomized trial, so obviously it's a blinded trial as well. So the points which in a journal club one would want to see when you critically evaluate is, how is the randomization done, and is that process fairly fair to both the groups? Is it that one group is favored in somehow or not? So I think the process which should have been to whether the randomization was good, it was blinded, was it truly blinded or not blinded, who were the people, it was double blinded trial. So whether all of this was done, I'm sure it was done, but the question is that
Yes, sir.
this is exactly what one needs to look at when you are doing a journal club. Then in the methodology, were these people treated the same way as was decided earlier in this study? This was a randomized trial. They had decided that this group will receive this. Was there any patients who developed infection? Was there a crossover? Somebody who was in the control arm, maybe he was also given taurolidine. This study was terminated early because of the effect. So how was it? Was the statistical method used? Was it appropriate for the kind of study that was done and all that? And since you had both the authors here, I would have liked that they could have given you some of these answers to some of the limitations that may have occurred. They may or not occur. The other thing would be, what are the advantages and the limitations of this kind of a study? That would be something that would be important. And then some of the questions which, like Amit has asked, that is subgroup analysis of some of the patients. Were there any patients who behaved a bit different than the other causes of ESRD in these patients, especially diabetics and non-diabetics, which Amit had asked about it. And also interpretation, which Dr. Prabir Roy talked about, the interpretation that the catheter rates were similar, removal rates were similar. So in fact, there wasn't any impact on the duration the catheters will remain there and all that, and the functioning of these catheters and the answers that you gave, they gave you. And so I thought that for journal club, these are the considerations which would be, and is the discussion appropriate to what the authors have found? Sometimes authors might give, and even though in US these days, reviewers may not allow them to go astray, but still some authors and people, influential people like Prabir and obviously Anil can get away with many other things as well. So, but that necessarily doesn't mean that the article should not be relevant. So I think I would suggest that these are the points which I think in a journal club are important to be taken care of.
Another point that I just wanted to ask the authors was, the effect, do you think similar for both tunneled and non-tunneled, or do you think in non-tunneled catheters you would have a greater advantage as compared to tunneled catheters?
So the study strictly included the tunneled catheters.
But
so we did not include
what would you hypothesize? You think that this would be...
So that That's an interesting question, especially if you consider that perhaps in some countries,
In
including
India,
India, I've
we
seen
use a large
use
number of patients are using non-tunnel to start
not
with,
a,
and
yes,
because of cost issues as well.
right.
So that would be another point to look at it to see whether we can, prolong the life of or reduce the infections in non-tunnel catheters compared to tunnel.
Yeah, so it will be speculation, as you can imagine. I mean, this was not the population included in this study, so I will take it apart from this study. So I would say that it should help those people who are using non-tunnel catheters also. But again, there is no trial, and this trial did not include anybody with the non-tunnel catheters. Predominantly, the catheters were IJ. 10% were subclavian. There was no femoral catheter. So it's hard to say, Dr. Gupta. I mean, it is a speculation. I mean, I can say, yeah, it's going to be really effective, but it should be, though. I mean, the mechanism suggests it should be. Yeah.
Anil,
Yeah, I
or
can
Prabir.
I can, yeah, I can.
No,
I
I
never
was thinking,
commented
well, you could
on-
answer one more question. Is there
Okay.
anything that you would be concerned about an adverse effect of taurolidine, which you may have seen or would have expected but didn't see it?
Yeah. Okay. So yeah. So I think I'm going to be a little bit stronger than you, Anil, in that first one. So in general, I would say, and this is not just for this is for any sort of disease or problem and the intervention. So in general, if taurolidine truly works, right? And it works across the range of infections, and we have no reason to believe that it doesn't, then if you have a very high, then the answer is that if you have a very high catheter infection rate per 1,000 days, the expectation would be that taurolidine would bring it down much more. And so, if you go to a unit with a very high infection rate, I think you're going to get more effect from taurolidine as compared to a unit where they do a really good sepsis. I think if you were to use it in with non-tunnel catheters, which could have 4, 5 times, 7 times some papers suggest the infection rate of tunnel catheters, I think you're going to have a bigger effect. So that would be unless there's something about taurolidine where you have a huge burden of infection and it doesn't work. I think that's highly unlikely. So the answer is, I think, yes, you're going to get a bigger bang for your buck where you have more infections. I'm not, Anil, I'm not being totally going down the straight and narrow here. That's my, and then Vijay, to your answer, what I can tell you is that there have been studies in patients with sepsis where 500 times the amount of the taurolidine that we're using in the catheter has been injected intravenously into these patients as a treatment for sepsis. And, I don't think it has worked, but I don't think there have been any side effects. So to me, and this came out in the early days of taurolidine, I was told this, to me, that has always been, listen, if you can inject this IV and it's not that the person suddenly dropped his blood pressure or turned red or purple, that's pretty good for me in terms of safety.
The other
Another question. You can go ahead, then I'll ask.
So one more question is that, do you think that this would reduce both gram-negative and gram-positive infections to the same extent, or would it be in favor of one of them?
That was the question I was going to ask, so you asked it. So I don't have a question to ask.
Sorry.
That's it.
Anil,
that's safe. That's good. Yes.
I will say, Anil, I'm going to hand it over to Anil. He's really been the person, I think, who's done all of the heavy lifting on this study. So all of you should know that. So,
okay, Prabir, thank you. No, I think Prabir's insight has been very, very helpful. So it is a broad spectrum. Taurolidine is a broad spectrum antimicrobial. So obviously, with the 56, CRBSIs, it is very hard to figure out, okay, it is going to be much more of gram-negative or gram-positive or fungus or whatever. It has broad spectrum antibacterial activity. It has fungicidal activity. We are going to be analyzing more into the types of infection. So your question is great. I mean, yeah, is it going to be useful to those people who are at risk of more of the, gram-positive infections or negative infections? We will be looking at that data. So we have not looked at that data yet. So it's hard for me to say right now, is it going to be one or the other? My feeling in general is that it is broad spectrum, so it should be pretty much equally effective. And I'm not as strong as Prabir, so as Prabir already said.
Maybe
I think it's going to be the same. Part of the mechanism, and I'm still learning more about this, is in attaching and in sticking on. And my thought would be that that's really good for biofilm. And I would have been really interested in looking at the catheters. That was supposed to be a part of the initial study, in looking at the catheters that are removed. And there's so many things you can learn about biofilm through electron microscopy, by looking at histology, by looking at the amount of thrombosis around the biofilm. So I personally think that was a huge lost opportunity. I think there were logistical and funding type issues, but again, yes, I think that would be very interesting for the future, definitely.
Arun, I would suggest that if there is a question
Vijay,
which is remained unanswered, can we have that question?
I was just going to interrupt for it, sir. There are two questions which we'll have to see. One is from Dr. Sanjeev Nair. It is about the higher rate of attrition, which has happened due to protocol violation in the heparin arm. What is the explanation for that? And the other question was on whether the same efficacy can be expected with both primary and secondary prevention of CRBSI. I think these questions we have not addressed in the chat box yet.
I can take the second one. I'm going to leave you the design. You're better at it.
Cherry picking.
And I'll give you I'll give you the opinion. I mean, my opinion has always been that, and this goes to the precision medicine part that Anil was talking about, that so number one, I would say, for that primary and secondary prevention. So by that, I'm meaning that, this is the first infection with a catheter, and then you have a second infection in the same, after the infection. I remain a believer that biofilm is the problem, and the only way to get rid of biofilm is to change the catheter. So I would advocate, and I understand that cost and other issues. We're not very successful at our center about changing the catheter every time that somebody gets an infection. But if you believe that biofilm is the big one, you're never going to get rid of the biofilm. And so when you treat somebody with infection, so the recommendations really are to do an exchange of the catheter. So that's the first point. But having said that, yes, I mean, my expectation would be that once is that if you were to try and get the biggest bang for your buck, then you should use it in units or in catheters that are likely to have a higher rate of infection. And catheters that are likely to have a high rate of infection are catheters that have already had a previous infection. So yes, I think it would be more effective there. The big thing about different catheter, it goes to Amit's question, is that understanding more about biofilm and its actual impact on creation of biofilm related to its mechanism of action, which is this attachment issue, that's a key question, because that's how it could separate itself from other antibiotic agents. And it's, we don't use them in the US, but we did try for a while, and there could be many other places, so new antibiotic agents that people may use. And so I think that is a very important question.
There was a study in Canada in PD catheters where they used silver impregnated catheters, PD catheters, to prevent biofilm formation. Has there been something? So all sorts of
of films have been all sorts of coatings and have been used. So I wouldn't be surprised. And I know that silver has been used definitely in central venous catheters. One of the problems with the FDA pathway, and I'm happy to say it, is that most of these go down a pathway called the 510K pathway, which basically means that you don't have to do a randomized controlled trial to show that a particular type of coating is better. And so you have all of these fancy coatings and expensive catheters that, in my mind, I don't know whether it actually works. I still believe that the single most important thing for good function is the size of the catheter. And the Tesios, I don't know whether you use them. We used to use at one time, which are 2 catheters. I thought they were really good because you had two big lumens. And then I've just remembered, of course, what I had forgotten that earlier. And I think it's important for all of us to remember that 4% citrate is not a very good anti-infective agent, right? It's more anti-thrombotic. But 25% citrate or 25.4% citrate is extremely effective as an anti-infective agent. And the reason that it's not available is that when the studies with this were done, that in 2 patients, they actually injected the citrate in, and that resulted in massive hypocalcemia, and it resulted in a cardiac event and actually, I think, death. And so that's the reason why we're not using citrate. But if we could work out a way that you are not going to, by mistake, push the citrate in. Citrate is at this high concentrations extremely effective in preventing infection.
Yeah, I agree with everything that Prabir said. So the citrate lost favor because of the risk of hypocalcemia in higher concentrations and not being antimicrobial in lower concentrations. So, but it is an excellent one. I did a trial at Ohio State with only 4% citrate. And we had for temporary catheters, non-tunneled catheters, and they worked very well, and the results were better than heparin. I did a paper, and I think and we published a small article on that. So question about the primary or secondary prevention is very interesting, because in the past people have tried antibiotic lock solutions for the secondary prevention, so or to salvage and also for the treatment of acute bacteremia and trying to save the catheter. I think the study was by Ted Saad or somebody. So in that study, they had a higher rate of metastatic infections. So yeah, you can probably use antimicrobials. I agree with Prabir that if there is biofilm, you need to get rid of the catheter, unless at some point we come out with a study with taurolidine, which is supposed to inhibit the biofilm formation. And if that shows that you can keep the catheter and not have to change, and you can decrease the biofilm, that will be something that will come up. The question about the heparin attrition, I would say that was just a function of being a randomized controlled trial, and I don't think there was any particular reason that we could figure out, unless Prabir has any thoughts on that. But the one question in there is about why there are more gram-negative infections in India as compared to states or the Western countries. I'll leave that to the Indian professors. Yes, and the risk of resistance for taurolidine, the mechanism of action does not, it does not fall to the occurrence of resistance. So there should not be any resistance to taurolidine, as far as I can tell so far.
Yeah, I think we are probably, Arun, are we done with any questions which are left? Yeah, you have a question?
I think we have addressed most of the questions, sir, and I think it's already 9. And
yes.
I would like to thank all the panelists, Vijay K.S. Amit Gupta, sir, our study authors, Anil Agarwal, sir, and Prabir Roy Chaudhary, sir. Thank you. The presenter and all the attendees for taking their valuable time and taking part in this. And we'd like to see all of you in next month's ISN conference at Kolkata. And because of that, we may not be having next month's Journal Club also. So till I see you in January, we'll probably meet next month. And thank you. Thanks a lot for all your attention.
I think we should, I on behalf of Amit as well, will want to, Shyam is also here. It's a pleasure to have both of you on this, and it's Shyam, I must congratulate Indian Society of Nephrology for starting this Journal Club journey and having the authors themselves be present for answering as well as giving an insight about this kind of studies is very inspiring to the younger people, and I'm sure your presence here would be a great. Thank you very much for sparing some time as well as being with us.
Thank you, everyone.
Thank you.
Very important topic, and we have been able to get a very good discussion on this very important topic. This is for India.
Yeah.
Like CRBSI is very common, and we can really address, and the discussion has been really great this time.
I only hope that this drug is available quickly to us as well, because we seem to be needing it more than Anil, that you need there in US, because our infection rates are definitely much higher.
I think that's absolutely true. And 16, 17 per 1,000 days is
very high.
It's unbelievable. So
yes.
I think there will be so much bang for the buck, and yes, we need that in India for sure. Absolutely.
Yes.
We must also congratulate our young presenter.
Yeah. Oh, he did a good job.
I was sorry, I was going to say that, Dr. Rathod, it was a very good presentation, and you were kind to us that you were not critical. So even though we wanted you to be critical.
Okay.
All right.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you. Thank you.
Bye.
Good night, sir.